Right, it's 12 o'clock. Shall we get going? Excellent. So welcome everyone, and thank you for joining me today. I've got an hour and a half of cytology content for you, and so we'll intend to go through a few cases. These are the real life cases that we're going to be reviewing, a selection of things that I've passed over my desk and I've just put aside as being useful examples of this, that, and the other. But first I'm going to introduce myself and tell you a little bit about where I sit in the organization and my background. So my name is Philippa, and I'm the clinical pathologist based in Melbourne. I started my training here in Melbourne as an anatomic pathologist and thought that that was largely about cutting things up. Doesn't really make me a psychopath, but I was expecting that from my pathology residency training, and I was really surprised to discover when I finally got into it that it was actually mostly sitting in an office with a microscope and a computer looking at bits and pieces and very little opportunity to cut things up. I spent 10 years doing a mixture of anatomic and then clinical, and then eventually decided that I'd got my family out of the way and I could get on with my board specialization, and decided to do that in ClinPath. And I went over to London and worked at the RVC as a lecturer for a couple of years, during which time I got that specialist exam in America. And then I came back to Australia, and I've been 3.5, nearly 4 years as the head pathologist or pathology services manager at IDEX. So I wear two hats, the Philippa hat, which is the one that does all the management of the pathology team, and we are 15 at the moment. So we're a big team with lots of different specialities, and I manage people all around the country and into New Zealand as well. So we have a lot of diverse backgrounds, diverse experiences and skill sets to bring, and I manage all of that, as well as doing the caseload for cytology here in Melbourne. My typical day looks like a mixture of cytology cases, some interps in what we call the queue, which is our biochemistry, hematology, endocrinology workflow, and answering the calls from clients as well. And on my direct reports from cytology or from any of my interpreted panels, you'll see my numbers down the bottom, and you're always welcome to call me. So the focus of today is going to be cytology, but I'm very open to questions. The way that I format these is literally just showing you on my microscope with a real-time camera view what I'm looking at and how I look at it, and then talking you through some of the processes. But I have whole boxes behind me of cases. So if there's something that you particularly want to ask me about, Alan is managing the chat function, and he can talk you through what's there. And so he will tell me and interrupt me to ask questions on your behalf. Your microphones are muted because otherwise with this many people, and thank you all for coming, it does get a little noisy, so we'll mostly be on mute. But if you want to ask questions at the end or halfway through, by all means, just do so. So I thought we'd launch straight into a case of what cell is that. And what I do is I share my screen. I've got the most beautiful Motic camera, which you should be able to see behind me, and I'm just going to put that over there. Let's see if I can get that sorted. Okay, so we've got, you should be able now to see my screen, and there's a lot of blood and there's a big clump of cells in the middle. And that should look fairly clear to you. It is a bit smudgy, but that's actually in the nature of the material. So with this many people, it's harder for this to be so interactive. Normally I'd be looking for feedback on what you see and what you think, and saying, what do you see? So it's a little difficult to do that with this many people. But here I am. I'm just going to walk down the microscope field and walk across it for you and show you what I'm seeing. So we've got a process of blood, and then we've got a lot of this material here. This is purple granular stuff. It always tweaks my interest for, what is this? Is it bacteria? Is it mast cell granules? In this case, the site that I've been told is that it's the prostate from a male neutered dog with typical history of difficulty passing feces or pain or pyrexia. And so I'm guessing and really quite confident that this is actually ultrasound gel. It looks so clear on the animal, but it's purple once it stains and attracts the basophilic dyes. And it's very, very difficult to see past. You can't, it looks just like bacterial cocci, it looks like mast cell granules, and so it can make interpretation rather difficult. So in the center of the field, I have a small cluster in amongst the blood, and I have to get my oil on my lens. I have a 50 oil immersion lens, which is wonderful because it means I can literally just jump from one to the next without having to worry about getting oil on my dry 40 if I'm going up to 100x, because my 50 is also a good oil immersion lens, and then I can skip across to 20 without it touching and contaminating my 20 lens. So I'm now at times 50, and I've got some size in my field to give me an idea. I've got a lot of red cells, and these sort of orangey blobs are all just mashed up red cells together. And those, it's a dog, so those are 7 microns. My neutrophils here are typically about 12 microns. They vary a bit more. So I've got some big, mushy goo here in the middle. And in amongst that, I can just about make out big nuclei with multiple nucleoli and fairly indistinct cell borders. And the cells are all clustered together. So that's one process that I have. And then moving back to this bit here, this is the other process that's present on this one slide. And I have a collection of mushy cells, a lot of cells where you really can't make out detail. You know, there's no cell borders, there's no margins to this. And then the odd one where you can see that this is a neutrophil. This has a segmented nucleus, this one here as well, this one over here. So this is a collection of degenerate and necrotic autolyzing neutrophils that are poorly preserved because of the process. So I can now say confidently, we've got a suppurative prostatitis. I'm comfortable that it's in the prostate because they told me it was, and then I see the odd cluster of epithelial cells, but also I've got neutrophils. So my next question is always, what's causing the neutrophils? Have I got bacteria? Have I got something really weird and wonderful? Have I got a neoplastic process in necrosis? And the answer will be a question of 5 minutes of hunting for bacteria in most cases, which I'm not going to subject you to, particularly with that ultrasound gel there, because it makes it so much harder to see. So my typical pathway when I look at this slide is to go round and round and round, up and down, looking for areas that are different, looking for a pattern. And here's a better example of some epithelial cells. So here we have most of the features of malignancy, and it's not a lot of cells. It is possible when you have inflammation in the prostate that the epithelial component of the prostate can be reactive, secondary to problems associated with inflammation and necrosis. But we have one cell here, a smaller cell, a nucleus or possibly a slightly disrupted lymphocyte, another cell here with an odd shape, and one giant cell here with irregular margins and 2 nuclei and nucleoli that are almost as big as a red cell. That is way too big for a nucleolus. And this one here, bigger than a red cell, that's a macronucleolus. We just keep piling word elements together till we make something that sounds really groovy. And so we've got big nuclei, we've got variation in size, so aniso meaning variation in between, and then karyo meaning nucleus, and we've got coarse chromatin pattern, particularly here. This one is very clumpy, and these big nucleoli. So there's a strong suspicion that this dog has suppurative prostatitis secondary to prostatic neoplasia and probably carcinoma, which is more common in male neutered dogs. So the next step for this patient in my recommendations for the cytology report might well be to do some culture, just to make sure there's not an infection, to minimize the secondary effects, and to consider biopsy. I'm usually going to say that because you might well feel very confident that your imaging findings plus the other changes are enough to give you a diagnosis of prostatic carcinoma, but I'm sitting here with less information than you have, so there's always a little bit of caution in that interpretation. So we're going to stick with the theme of inflammation, and I've got a joint fluid here. And this is a nice opportunity to tell you a little bit about joints. My aim in this talk is largely to give you things that you can use as first opinion in practice. You know, the Saturday cytos, the evenings, or when the owners don't have the money to send away, or when you feel comfortable to look at something and then decide at that point whether you're going to send it off for a second opinion from myself or my colleagues, or whether you're just going to make the call based on your cytology and your level of skill and comfort in that process. So when we sample joints from dogs and cats in particular, the main differentials are an immune-mediated polyarthritis and non-immune inflammatory disease, including sepsis, but also traumatic and related to surgery and things like that. And so the way we price our cytology for joints for dogs and cats is that we don't charge for multiple joints. And the same applies to lymph nodes. And that's to drive best practice. We want you to submit multiple joints. We recognize it takes more effort to prep and sample, but it's the only way to make a diagnosis of IMPA compared to sepsis or other non-immune processes. In horses, we treat it slightly differently because we assume that in every joint in a horse, you're looking for sepsis. So I'm spending longer looking for bacteria, and it's a very fruitless search in many cases. It's really quite rare to see bacteria in joints. But if I have a dog with 3 joints all having massive numbers of neutrophils, I might look briefly, but I'm not going to spend half an hour driving up and down looking for bacteria in that case because it's not relevant. So this is the direct smear from a joint from a dog, and normally the rule of thumb with joints is that it should have a really thick purple background. There should often be streaming of cells. We call that windrowing. The viscosity of that joint fluid pulls along the smear as you make it, or if you just make it by dropping and pressing down, it will lead to blobs forming vertically where it's thicker, where it's pulled off against the next slide. And you should see, if you go to 40x, no more than 4 cells per high power field. And that's your mental rule of thumb for how cellular is this. So this is me at 5x, and you can see there's quite a lot of purple. I'm going to go in to 10, and already I'm starting to see I've got red cells, and I've got round cells. They're not sticking together. This isn't the membrane of the joint. This is an infiltrate of round cells. Up to 20, and we're starting to see, hopefully you've got good enough screen resolution, you can start to see that these are segmented cells with neutrophils, with nuclei that are complex, and then some bigger cells as well. We've also got smashed cells. That's common, both because they're fragile and because of the processing. So all I need to do is find a bit, usually on the edge. And at the edges of the smear is where the cells will be a little bit more flattened out and easier to see. I want an area where there is less thick background. So I'm going to go here. Sorry about the movement. If it gets too much, you just need to look away for a moment. I'll try and keep it fixed on one place on the slide for a period of time. Okay. So my camera just brings the light in a little slowly there. So we've got these erythrocytes, and we never really look at the morphology of the erythrocytes on a cytology prep. We're not going to make any judgment on them. These are all crenated because of the way they've dried. We've got neutrophils, and you can see that they've got these complex nuclei, but they don't look quite like they do in the blood smear. Their nuclei haven't got the thin areas of segmentation between each of the lobes. So they're a little degenerate, and that's the term I tend to use in cytology, meaning the neutrophil is activated and has started to begin its own process of falling apart. Now that happens in most tissues when there is a level of inflammation that's associated with a cytokine-driven response. And that often is associated with bacteria, but often just the severity of the inflammation and the inflammatory storm that develops in that tissue. So it means something, but not everything, when you see degenerate neutrophils in your report. These cells here, these will be macrophages. And macrophages are one of the cells that people find the hardest on cytology because they can look so variable. And I'm going to show you quite a few examples of different macrophages as we go through the tissues. So if this was one joint that you sent me, the answer is suppurative arthritis. do culture, I didn't see bacteria. If this was a second joint labeled as to site, then I would know that it was 2 and they were both the same. Then your diagnosis is consistent with immune-mediated polyarthritis, and you can go straight into treating that appropriately, unless it's a tiny baby puppy or incredibly immunocompromised. The incidences in which I get multiple septic joints from a dog or a cat is extremely rare. I have seen it, but it's right down my list diagnostically. So that's why I have promoted that particular structure for pricing. Okay, so that's a joint for the day. Let's now have a look at this one. This is a submandibular swelling, and it's a good opportunity for me to bring up a really interesting scenario that I've seen recently in Melbourne. We have generally one clinical pathologist doing the majority of the cytology in each place, which gives you a good overview of the local cases. And you start to get to know clients that submit regularly, and you start to form that diagnostic relationship where we can support each other. But it also allows you to follow some trends. And so I know that in Melbourne, with the climate that we have, beginning and end of summer, spring and autumn, I'm going to see more mycobacterial cases, for example. And I'm not sure what it is, but at the moment I'm seeing an awful lot of suppurative lymphadenitis cases. And I've actually raised it to the chief veterinary officer and said, yeah, this is a little unusual. They're in dogs. And it's not just throat and pharyngeal stick injuries, but I've seen it in the popliteals. I've seen it in other nodes. And if it was a cat, I'd be thinking something along the lines of FIP is there a little bit of that going around locally, and we won't use the coronavirus term anymore. But in dogs, it's really unusual. So we're being mindful of that. And if you get any cases, I'd encourage you to consider whether they're worth putting forward for some further investigation, because we don't have a cause. It may just be chance, but there's enough of them to be interesting. So this is a throat aspirate. It's from the slide is labeled submandibular swelling, which is really helpful to me because immediately it's put it in my mind as to where it's located. If you just mark on the diagram and just throat, well, there's a lot of structures in there and a lot of anatomy that I have to try and consider as part of my differential process. So whatever you can give me in terms of really narrowing it down, describing the exact location, other structures that you've had to go through to reach it, how big. I can cope with fruit, but centimeters is easiest. And also telling me things like what else is going on with the dog. Does this dog have pyrexia? Does this dog have a cough? Does it have vomiting and diarrhea? All those kind of things are useful to me. So this is another example. We're at times 10. We're going to go a little closer. And again, it's all neutrophils. So it seems a bit like I'm laboring a point here. But the reason I want to show you these is that neutrophils can often be very difficult. And anyone who does a lot of urine, this is a hair because it's been sitting in my slide box. So there's a hair on the top. Not mine. Mine have artificial coloring. The neutrophils are variably degenerate. And because I know this is a submandibular swelling, my first and immediate jump to is this is going to be septic. There's going to be some bacteria in here somewhere. And I'm going to look for a fair length of time. And even if I don't see them, I'm still going to be advising that you might want to consider culture. And I might be talking about investigation by imaging and exploration rather than recommending you do a biopsy. Biopsy is not really going to help you here. This is a cut it and see kind of scenario. And as you see, these neutrophils are really variable. And I'm moving along the edge of the slide because that's where they're most spread out. And here we go. Now, I might go up one more power. This is my 100x lens, and you'll all be very jealous. I have the cost of the lenses is greater than the cost of the scope itself. So here we go. Long, filamentous, and not blunt-ended, but kind of fine-ended bacteria. And the neutrophils in this area are so degenerate and lysed that they're just blobs, and you can only just make out that they were once segmented nuclei, but there's no intact cell here. So I can't tell you that they're intracellular, which would be a significant, important thing if I'm looking for contamination, say for avoided urine sample. Are they in the neutrophils or are they just in the background? Here it doesn't matter. No, you've already told me it's submandibular. I'm trusting you to have made a really nice clean slide. It was one that we stained in the lab, so I know my stain is clean and it's not a risk from ears cytology contaminating and putting bacteria onto the slide that shouldn't be there. So I'm really, really comfortable that this is a septic, separative process. I can't tell you if it's a lymphadenitis. I just don't see lymphocytes here. It may just be pharyngitis. It may be a pharyngeal stick injury or some other sort of foreign body penetration would be the usual process for this one. Any questions? Feel free to put them in the chat. I think Alan can get them to me and I can see them coming up on my screen here.
No questions yet, Pippa.
Okay, cool. So where are we going to go next? Let's have some tumours. Here's one. Oh, this dog's called Priscilla. I love that. I always like the human names and the animals. They always make me laugh. All right. Lost it. Here we go. So my process when I look at a slide, and I'm looking at it first like this on the just as the glass, and I'm thinking, this one isn't going to be particularly revealing. There's not a lot of material. And I would encourage you when you're preparing your cytology to look at the slide grossly. If you can't see anything on it, it's not going to be diagnostic. It took me quite a long while to figure this out when I was in practice. I have to be able to see material grossly for it to be useful. And what I do when I aspirate is splatter it across, and then I just take one more slide. Here's an example. And there's no pressure to this. It's just put the slide on top and then slide along. There's no crush. It's not a squash prep. It's a caress prep. We just caress the slides together. If it's still got a lot of thick material, then I'm going to do it again and again. So I might make 6 from one smear and one suction process because the material's not spreading out well. If there's a really thick loopy bit, I might take the edge of the slide and just roll it across and tip it across so that it's had a chance for the cells on the outside to exfoliate. And I would do the same with a bone marrow core, for example. I would take that core, I would roll it across a slide or two, and then at a distance, drop it into the formalin, take my slides away, and stick that core into the formalin for the histo as well. So lots of different ways of handling the slides. The other thing I'll tell you about later is how to make fluid preps and make those more valuable for you. So this example is just a fairly limited cellularity. Now, I really would encourage you to at least stain one of your slides in-house for 2 reasons. One is you get to see if there is material and maybe not waste the client's money if there's nothing, or if it's really just smeared stuff, and you'll start to feel more comfortable with what is smeared and useless material. And the second is that you might well be able to make a diagnosis and not need me at all. The lipomas, you can keep those. They don't interest me. So this one, I can see there's material. I'm quite happy to restain it in the lab if I didn't like your staining, and I'll often give you some comments on give it a bit longer in the pink, give it a bit longer in the blue, maybe tip your stain out and start again because you've got some bacteria growing there. Maybe chuck that back to slides up because there's fungi growing along one edge. All of those things, I hope that you take them in the right way. You know, they're intended with the greatest of respect to make your cytology process more enjoyable. So, and you'll see hopefully that when I'm sitting at my microscope, I'm able to sit bolt upright and comfortably with my microscope sitting just where I want it. And obviously that matters a lot to me because I'm doing this for 7.5 hours a day plus. But it's really nice if you have the same opportunity to set up your workstation so that you're comfortable. And then I'm going to take this slide, and I'm at the lowest power, and you can just see the edge of, my camera's a little bit twisted. You can see the edge of the slide here, and there's some debris along. I use this debris to teach me where the edge of the slide is, where the edge of the field is, because I'm going to do what I call a castellation technique. I'm going to go down and along and use the debris to move from one side of the field to the other. And then I know I haven't overlapped and I haven't missed any bits of the slide. Then I'm going to go up and across and down and up and across. If I get to the stage of the day where I'm having to just skip straight to the lumps of stuff, then you know that I've had a big day. So I want to make sure that I'm going to see everything on the slide at low power. I'm not going any closer than 5 for this. That would be tedious. I'm seeing a lot of debris, and then I get, oh, look, there's a bit of stuff. But what I'm going to do is I'm just going to keep that in my mind. I'm going to carry on all the way across the slide. I know where that is, and I know I'm going to find it easy to relocate. And then I'm just going to make sure that there's nothing else on here that looks different from low power. So here I've got a scattering of cells. I can see that they are dispersed, that they are not in any way connected to each other. So immediately I'm thinking of a population that is designed to move and not designed to be coherent. Cohesive, that would be better. Goodness, that's a good non sequitur. So we've got a population of cells, and we've got some clumps of material as well. We've got round cells that are spread and clumps. All the way over, more clumps, great big streaming strand of something here. Oh, where's my mouse gone? There we go. So I've got my mouse visible for you all. And then at the end, this is often a really nice part of the smear to look at cells. You can see that this scalloped edge is like the feathered edge of a blood smear. It's where the cells have been pushed along to the edge. So all the big ones have been pushed right to the end by that smearing technique, and they'll often be quite well spread at that point. But I'm still going to be diligent. Off I go right to the end of the slide. There's some more stain deposit. This isn't, I'm just going to show you this. So this is the eosinophilic part of the diff quick. It's not ultrasound gel, but it also makes it difficult. So when you're getting a lot of this on your slides, you can stain a clear glass slide and see how much of this you get. If you're getting this, you can either filter your diff quick through coffee filter paper, if such a thing still exists out there, or you can just toss it out and start again and wash the pots out in between. If you don't do much cytology in-house, don't even bother having pots for your diff quick. Instead, lay the slides flat over the sink or a surface that you really don't care about. Flood each slide each time with each of the stains in sequence. So you can just take a pipette, put stain 1 or the fixative for a minute, tip it off down the sink, and then just tap it on the paper. Then lie it flat again, flood it with stain 2, 60 seconds or thereabouts, tip it off. Stain 3, 60 seconds or thereabouts, tip it off. And that way you don't contaminate your stain with gunk from your ear cytology or your skin preps. You don't use a lot of it. It seems like a lot as you're tipping it off, but actually for low numbers, you're just going to get better quality that way. So there's the stain deposit. And that for me means I know here's the end. This is the end of the prep. I'm just going to check there's nothing in the tail. Our cytology staining machine is automated and it misses the last ½ centimeter of the slide. So if there's no material on the rest of the slide, I might have to go back and get that little bit restained manually, which is a nuisance. So try and keep the material between the frosted end and the last centimeter of the slide if you can. So off I go. I'm going to go back to some of the bits I've seen already, and I'm going to zoom in and have a little look. So if anyone wants to write in the chat, I can call the chat up for this because I think this is really a useful exercise. If anyone wants to write in what they can see or any cell populations that you can observe at this point, then I want to know what you spot. There are no completely wrong answers. There are some slightly off, but we'll see what we get. Go for it. You might all have to nominate a person. Would you like me to go closer? So because I've just been using my 40 oil, it's got some left on it, but still have to put a little bit more on. Is it getting any easier? Oh, don't know about that. I can't, no, I'm not going to let you annotate it, sorry. Just chat to me. Anything coming through? Okay, good, good. I've got some comments here. So, right, so we're getting some comments on spindle cells and neutrophils. So I'm going to help you out here. I'm going to go for a little wander, and I'm going to see if I can give you a contrast. Definitely some spindle cells. Now, we haven't talked about spindle cells yet, and we will. We'll start going through different tissues. But these Absolutely. Elongate, sort of stretchy things. And the spindle is like the back of a chair, a wooden chair, that long, thin bits that you might use to make lace bobbins or, that sort of shape, with the nucleus often in the middle. So we've definitely got spindle cells. Look at this great long one. Got pinky granules in. It's really stretched and fusiform. And then somebody's commented, macrophages with vacuoles. Yep, quite probably. This one's certainly vacuolated. What else have we got? Somebody has commented, we've got eosinophils. And this is where I'm going trying to find you a neutrophil, because a lot of people really struggle with eos and newts. And when you've got a contrast, it's easier. But if you haven't got that contrast, then on the blood smear as well, it can be really hard to say which is it. I'm going to go back and find that lump of stuff here. Here's a big lump of stuff. Here we go. So we've got a macrophage and very weird and knobbly nucleus. It's just a macrophage. They just do that sometimes. This one's an eosinophil with the pink granules. And you can see how there are pink granules through the background as well, and some purple as well. So we've got a mixture of pinky peachy color, some purple ones, and erythrocyte, slightly different color from the eosinophil granules, and then some lysed cells. We've got another spindle cell here, and then we've got something dark and blobby over here. But this one is probably a neutrophil, and you can see it hasn't got the granules. Now, I've got some ClinPaths on here today. Some of them might say, well, I think that's just a macrophage and a small one. I think, well, we can argue. Nobody's ever going to know. But it's in that sort of pattern. So here's more spindle cells. So for me, as a mental process, whenever I see eosinophils, I'm thinking of 2 or 3 main processes. I'm thinking about allergic disease and hypersensitivity. I'm thinking about parasitism, and I'm thinking about mast cell neoplasia. The others are uncommon. So paraneoplastic eosinophilia is something I do occasionally see. But those are my big 3. And this is a lump on a dog. So I'm interested. Nobody in the chat, as far as I can see, has actually, oh no, we've got one person has picked up on these purple cells. So the spindle cells stand out, but actually at low power, these really, really dark cells are the mast cells. Yeah, dark granules in them, absolutely. So these are mast cells. This is a mast cell tumor. And I remember probably nearly 3 years into my career when I was just getting into clinical pathology rather than anatomic, getting really worried about the spindle cells in a mast cell tumor and saying to one of my more experienced colleagues, what do I need to do about this? Is this a spindle cell neoplasm as well as a mast cell tumor? And he said, no. Mast cell tumors just do that. They induce edema, they induce collagen proliferation and damage, and the response of the body is this fibroplasia, this plumping of the spindle cells and separation. So when you feel a mast cell tumor, it might often feel like a lipoma. It might feel soft and squidgy. It might palpate as fluidy. It might fluctuate. And all of that is driven by the mast cell granules and the eosinophil granules. And so they can be firm, they can be nodular, they can be deep, they can be infiltrative, they can be pretty much anything they want to be. And a lot of them will feel like lipomas, which is why I always think it's a good idea not to just throw your lipomas in the bin. I've seen plenty of lipomas that have a mast cell tumor hidden in the middle, so cut them open, and if there's any brownish or darker bits in it, then make a direct impression smear from the inside and just have somebody check that it's not got mast cells in it, preferably while you're still doing the surgery or closing, so that you can go back and take more margins if you discover something unexpected in there. So are we comfortable with mast cells? Shall I go a little closer again and just show you a few individuals? Because it's obviously one of the ones that when you're really comfortable with mast cell tumors, you can toss all of those in the bin or keep your slides on the file so that you've got them available. Oh, there's my air bubble coming in. Let me put a little bit more oil on, and that will get rid of the air bubble. So it's hard. You can just see this really dark blob. You could sort of imagine that there's a paler bit, which is actually where the dark blue nucleus is, and it's pale because the granules are so dark. And then you have to start using the imaginoscope and saying, well, there's a few purple granules on the edge here. And every so often, you'll find some cells where you can actually see the granules, like this. So there's my nucleus, and there's my granules. Cytoplasm's a little bit disrupted. This one's a macrophage that's eaten purple granules just to make life harder. Because macrophage's job is to mop up. And here's a nice mast cell. It's got the nucleus visible, a little ring around the nucleus where it's cleared and doesn't have the granules, and then this purple grainy appearance. Okay, so a mast cell tumor. Some of them are much easier than that one, and I can certainly show you some of those. So let's have another one. Here we go. So try back to low power. Here's a much better example. Is everyone happy with this one? This one's got the blood, and don't be afraid of blood on your cytology. You know, a lot of people say, I couldn't get one without blood and I didn't submit it. And I said, well, actually, sometimes blood helps to spread the cells out. It allows that smearing effect. If it's so bloody that your whole syringe is filled with blood, then there's no point. But you don't want more material than is in the hub of the needle. But we can cope with a little bit of blood, and sometimes it makes it easier, and sometimes it's just something you read through. It helps often to know what the leukogram looks like in the patients where you don't think you've got many cells, and so we can sort of filter through which of these are leukocytes from the blood. If your patient's got a massive leukocytosis, it's going to look like an inflammatory process on your cytology as well, and we might misinterpret. So a mast cell tumor, the nuclei are so pale in this because all the stain's been taken up by the granules. Can you see how they're all separate? The cells aren't clumping together at all. And that's because mast cells are one of our round cell populations. And I like to explain the difference between round cell, spindle cell, and epithelial cells by the way that they function in the body. So this is a concept I started introducing to my undergrads at the university, because often you go through anatomy and histology lessons and you don't really grasp the different functions. So I think of it that the epithelium is always lining a surface that's exposed to the environment. So you can take this as an analogy, and it becomes a little quirky to think about. But obviously, the surface of the skin, you know, fingernails, everything that's on the outside of the body is epithelial. It forms that direct barrier to the rest of the world. But everything that connects indirectly to the surface, so the inside of the oral cavity, down the esophagus, down the digestive tract all the way to the anus, and the anal sacs are all lined by epithelium. But you can imagine yourself as a particle of food or a bacteria trying to find your way in. Think of walking through the esophagus down to the stomach into the gastric glands. Think of walking up the bile duct. And the last thing you meet as you go along the bile duct to the very last cell that interacts with the bile production is the hepatocyte. The hepatocyte produces bile, and that flows through the bile ducts and the canaliculi into the gallbladder, into the bile duct, and out into the gut, all indirectly connected to the outside world. So a hepatocyte is epithelial. If you think of the same, you can go up the urethra or up the genital tract all the way to the outside of the ovary, because a follicle comes off the ovary and goes into the oviduct and into the uterus. The sperm, all the way up the urethra, past the prostate, which is also epithelial, produces to the outside, and up to the testes, which produce the sperm that get to the outside. So the testis has epithelial components, and the bladder, all the way up the ureters to the renal pelvis, and the tubules producing the urine that gets to the outside. So the kidney is mostly epithelial as well. So anything that you can think of a way that it connects to or produces to the outside is going to have an epithelial component. Things that don't connect to the outside, thyroid gland doesn't actually produce to the outside. It's a bit of a misnomer. We think of it as an epithelial tissue, which is weird because it's glandular. At one stage in development, it probably did, but it doesn't anymore. The spleen doesn't. But then we have the mesothelium, the lining of the cavities, and that lining of the cavities, mesothelium, is a kind of epithelium. It's because we were once open when we were developing as embryos, you know, big flat plate, and we've circled in and brought ourselves together. And so the lining of the football has epithelium as well as the outside of the football. And so you have epithelial tissues in there as well. The spindle cells are things that are meant to hold together. So they're the matrix, the bricks and mortar, rather hiding beneath the plasterboard and the render. And so those are cells that are connecting things together, but they don't connect to the outside. So anything that involves connective tissues, muscles, bone, is a spindle cell component. And the round cells all came from the bone marrow. Every single one of them came from the yolk sac originally and then migrated to the bone marrow, and then its purpose is to move around the body. So we have our 5 round cell populations, which are the 5 leukocytes that you see in circulation. But we also have our populations that are equivalent or similar in the tissues. So if you think of the 5 leukocytes, does anybody want to try and name them? Or is it too slow to try and write in the chat? Talk among yourselves for a moment while I pick up the next case and see if you can think about what your 5 populations are and any other round cells that you can pin up. I'm going to give you the next couple of these. I've lost my slide. 4, 2, 6, 8. Where are you? Here we go. I'm going to give you a few round cells, and this is one of the joys. Okay, lymphocytes, macrophages, neutrophils, eosinophils, and basophils. Well done. So those are the 5 on our hematology profile, and from those, everything else connects. So histiocytes and macrophages or monocytes are all the same lineage with different development and pathways. Langerhans cells, dendritic cells, they're all kind of in the same pathway as the monocytes and macrophage lineage. So we think of those all the same way. Neutrophils are just neutrophils, eosinophils are just eosinophils. And basophils and mast cells share a common precursor. And so we kind of lump those 2 together as a function. And then lymphocytes, T and B and others are cells. And who can anyone think of what the other cell that's derived from a lymphocyte is? So I'm going to give you a series of round cell cytologies. And people often tell me, I vividly remember somebody saying to me, oh, I'm really comfortable with the big 4. I'm comfortable with lipoma, mast cell tumor, lymphoma or lymph nodes, and histiocytoma. And I thought, wow, 2 of those are my hardest. Those are the ones I'm least comfortable with. The advantage of being the clinician rather than the pathologist is you get to see the dog in front of you. So if you've got a small mass on a 1-year-old boxer and you get round cells, well, you're going to be comfortable with that. If you don't tell me how old the dog is, I'm not going to be comfortable with that because there's so much overlap between the round cell populations and so much potential for a massive difference in prognosis. Because a benign cutaneous histiocytoma is a true surgical emergency in that you can't make any money from it if you don't cut it off this week. But a lymphoma is going to be devastating in the skin compartment well, realistically, by the time you find it, it's probably going to be devastating anyway. But the chances of you cutting that off and making a real difference are fairly slim. And a plasma cell tumor can be anywhere in between. So this is one. It's a lovely example of round cells. So I've got a lovely purple background, and that's sort of a proteinaceous tissue fluid. Very few erythrocytes. Okay. So we've got very few erythrocytes. We've got the odd neutrophil, one here, one over here. And then this population is bigger than neutrophils, the nuclei are about the same, but there's quite a lot of cytoplasm. And when I look at this, I'm looking at the cells with a good filter. So this one doesn't have any cytoplasm. I just see nucleus with nothing around it. This one has more. I can actually see the edges of it. This one I really can't make out cytoplasm. It's not very obvious. So I'm going to ignore all of these cells that I can't see the cytoplasm and just say naked nuclei. don't even try and interpret the naked nucleus, because once it's got no membrane, it can fill with fluid, and suddenly bits that weren't visible, like nucleoli, like chromatin pattern, look much more aggressive or neoplastic and malignant, and they're not. They're just filled with liquid, allowing them to separate. So we've got these fairly big, round cells, mononuclear. Some of them have darker margins, and some of them have a perinuclear pale zone. And every so often you might see one that's a little bit sort of not quite ovoid, but even a bit potato-shaped or indented. Sometimes we get fancy and call it reniform, but I can't see one of those as really truly reniform in this area. So I'm starting to look for features. Oh, look, there's a mitotic figure. And this mitotic figure is a bit splatty, and you can see the little chromosomes individually. But they told me that this was a 1-year-old dog. So I said, this is a histiocytoma. No big deal. Just wait and see, or cut it off if you prefer. If you do cut it off, stick it in a pot of formalin and leave it on the shelf, because if it causes concern in a month's time, or there's regrowth or something unusual, you might decide at that point to send it in, and it won't be too much harmed for that length of time in formalin. We might not be able to do immunohistochemistry on it, but the histo itself will be absolutely fine. This is a different lump from a different animal, and this one's a really different presentation. But again, cutaneous lump with lots of things going on. So let me just check I've got the right. Yeah. So this is a 13-year-old female neutered dog, and it's a population from the skin. So we've got lots of different cells present. And it's a case of filtering through the processes and trying to say, is this inflammatory? Is it not? And if it's inflammatory, what kind of inflammatory? And if it's not, what kind of not badness do we have? So lots and lots of cells with poor margins and not very good preservation. We'll try and find a good spot. So I'm just going to wander slowly across this. Look away if you have to, and find a good area. Okay, let's try this. So this is going to be one of those cases where you get a report from me that doesn't always satisfy. And it's frustrating, because I fully understand the frustration. I was in practice for only a couple of years, but when you get a report from the pathologist that doesn't tell you what it is with any confidence, you end up thinking, well, why did I bother? But this is difficult because a number of reasons. One is these cells, this is mostly just mush. They're all just squashed together. And it's so tempting to say, look at that nucleolus. But actually that cell has no margins. So that could be just artifact. There's a cell down here, which is intact. And I can see a nice sharp margin. And I can see that the cytoplasm is full of vacuoles. But I can also see a big nucleolus in that cell, and a relatively big nucleus compared to the erythrocyte next to it. So if this is, you could fit 2 or 3 of those in that nucleus across. And the nucleolus itself is almost the same size. There's another one over here that's quite nice and intact. It's got dark blue cytoplasm, some vacuoles, a big nucleolus. And then I've got some smaller cells and sort of intermediate. So there's a lot of variation. So I got as far as round cell in this. To me, subjectively, they don't look like macrophages. Macrophages don't tend to have big nucleoli, and they don't tend to have very dark cytoplasm. They often have vacuoles, and there's a lot of overlap. And I'm sure that some of the cells in here might well be macrophages, but it's hard to pick. I've just gone with round cell tumor, and overall, my preference was actually for lymphoma. But that would be an unusual diagnosis in the skin, so I encourage them to progress to doing more on this if they would have changed, if it would have changed the diagnostic pathway. So some lymphomas on the lymph nodes will look like this, and when you see enough lymph nodes, you start to get comfortable with a huge, huge spectrum of what lymphocytes will do. There's an eosinophil just here, and there's a typical small lymphocyte for contrast, same size as a red cell. And so these big, nasty cells, I'm going as far as it's neoplastic, and it's not one of the common benign neoplasms. It needs treating with a lot of caution. So then we've got a third one, which is, again, on a theme. Just scanning through looking for a good spot. Again, the bits that I like to look at are not the thick red cell areas, but the areas often around the edge where there's a, almost like where you'd pick in a blood smear, where there's a monolayer of red cells that tends to be that nice flattening of the other cell populations. So straight away, I'm looking with my sort of, when you're doing those funny 3D pictures that jump out at you, I tend to use my soft focus look and just sort of, oh, look, there's a variation here. I can see some changes in color. I can see some changes in size and some patterns related to different distribution. And then I get a little closer and I start looking at the individual cells, but I always resist getting too close too soon because it's so easy to get fixated on one cell that looks interesting or scary and forget the bigger picture. So a little bit more oil. With regular cytology, you should never need to go to the 100x. Save that for when you're really hunting for bacteria, mycobacteria and things like that, because it's just too close. You don't get the big picture. So there's some features of malignancy here. This is a mitotic figure. These are platelets, and we expect that to be from the blood. These neutrophils may also be from the blood. Then we've got some smallish cells, some medium, and here's the big daddy cell. That's a huge one. If you think this is 12 microns across, the nucleus of this is probably close to 24 microns across. That's really big. I'm not really seeing a big nucleolus. Here's maybe a little nucleolus here in this cell and maybe another one here. What I'm seeing is more sort of slightly clumpy. You can sort of imagine a face in it. There's its smiley mouth and a couple of sort of clumpy eyes, but you know, pathologists are nerds. There's a cell here that might be one cell with two nuclei. Not really clear. This one, again, looks like one cell with two nuclei. And this one over here in the very corner. So I'm looking at this population. They look really quite scary in terms of features of malignancy. Mitoses, anisokaryosis, and binucleation, some of the features of concern. But again, you can see the distribution. They're just scattered like buckshot all over the slide. They're not hanging together. They're a round cell population. So we've got our 5 round cells, and you know I've already showed you a histiocytoma and a suspect lymphoma. We know they're not eosinophils and neutrophils or basophils. So what else can they be? I'll give you a moment to see if you want to put anything up. But this is one of those cases where it's a trap for the unwary. This is, anyone having a go? The history on this one would probably be a nodular, well-circumscribed mass, often on the digit, sometimes around the anus, sometimes just randomly on the skin somewhere else, but often limbs or around the head, and older dogs. This is a cutaneous plasmacytoma or plasma cell tumor. It doesn't really look much like plasma cells in a lymph node on cytology in every case. Sometimes it does and sometimes it doesn't, but it's a classic presentation of round cells. The differentials, and I always include differentials for every round cell tumor I put up as a diagnosis, would include histiocytic nastiness, and not the benign cutaneous histiocytoma, but the histiocytic sarcomas, cutaneous and systemic histiocytosis, rarely lymphoma. This isn't a typical lymphoma presentation with the size of these nuclei, but nastiness generally. Hello? Cool. So there's another spectrum of round cell tumors. So we've done mast cell, we've done plasma cell, we've done histiocytic, and we've done lymphoma. How about some other tumors? Does anyone have any questions? Feel free to put them in. If you've got any cases you just want to see examples of, we can do that too. I can pull virtually everything off my shelves in not too long at all. Okay. So this is Penny. I love it when the name's on the slides. It really helps me. If you write in pencil, it won't dissolve in the stainer, and that makes my life a lot easier because I like to double check that the slide is labeled correctly. It's easy to pick the wrong slides up. I'm not numerical at all, so if it's got a 3-3 or a 1-3, I might mess up, and I do far too often as a simple human error. So that name and the site on the slide really helps me to just make sure that I'm getting it right. So this is one I've put aside as a good example. I'm looking at it going, oh, it's a terrible example. It's really not easy to see. I'm going over it fast, and I've got dust on the slide as well, but bits of debris. I've got clumpy bits and some blood. So already I'm thinking not a typical round cell population. It's all just at low power, not going any closer yet. I'm disregarding the background, disregarding the blood. And then, does anybody know what this is? See how I can focus up and down? If I drop the condenser down, that comes much more into focus, or much more obvious. But I like to sit with my condenser right up beneath my stage because that gives the flattest plane of focus for cytology. I drop the condenser down if I'm trying to look for parasites. So if you want me to do your skin impression smears for you or your deep scrapes to rule out Demodex, I'm going to drop my condenser down. I'm going to stick no closer than 10x and on my objectives at least, and I'm just going to scan up and down looking for that. And the little wigglers will jump out at me because I've seen enough of them. I probably see less of them than you do, to be honest, because most people don't submit the skin scrapings, and I'm not sad about that. I like looking at aspirates. So does anyone want to have a go at what these cells are? I'm not getting anything in the chat. Maybe you've all fallen asleep. Stand up, jump around. I'm going to say that we've got a couple of different populations. We've got some scattered buckshot cells. We've got cells just distributed evenly across with no connection to each other. But we've also got these clumpy bits, little sort of clumpy bits here and here. This one in particular, it sort of has a scalloped edge to it. And this one's a little bit more variable. Can you see how when I focus up and down at 10x, things are coming in and out of plane? It makes you all go a little bit nauseous. It's hard for me to take photographs of these cases for you to go on your VetConnect Plus accounts because the plane of focus is just more than my microscope can handle. So I'm going to zoom in on this. And this is another skin lump from Penny. Can you see? It's hard to make out the individual cell borders because they're so clumped together. But here, where it's out of focus, you can actually see them slightly better. Little lines, junctions between the cells, delineating each one. And the content of the cell is the nucleus. Sometimes looks like it's a bit squished over to the side at the edges here. And then these vacuoles. So we've got one brave person who's written something. And this is one that is really common. If you saw it clinically and grossly, you would have your mindset in a totally different place. It's and these are neutrophils as well. So we've got two processes going on. We've definitely got some inflammation, but this is the main process. That's slightly better. Foamy cells, they're big, really big compared to the erythrocytes, which I've just left out of focus for you. The nucleus is a medium size. They're fairly uniform. So this is one that you kind of, it's hard to say, but to me, these nuclei all look like the same size once I've compensated for the 3 dimensions and the squishiness. So they don't look terribly exciting nuclei to me. Fairly uniform, mostly oval, a few clumpy bits of chromatin. These are actually sebaceous cells. This is sebaceous adenoma. Sebaceous adenomas often get irritated. They, traumatize the dog, and the dog takes the head off it and pulls around at it and chews at it. So we often have other things like the inflammation, often pyogranulomatous. We often have squames, and this isn't a great example, but this is a squame. It's turquoise in this case. That could be from the skin of the dog or the handler or somebody in the lab. My lab staff are all wearing gloves, but it can still happen. And if it gets on there before we stain it, it's going to get stained. This is another squame, a purple one. It's really sharp-edged, nothing in it, sort of just amorphous purple keratin. Here's another squame here. And I point those out because they're useful to know when you're looking at, you know, an interdigital lump and all you've got is neutrophils and macrophages, and then some of those, well, that's a furunculosis. The squames have come from the epithelium, assuming that you're really comfortable that everyone was holding it well and carefully. So some debris, little bits of squamous fragments in amongst the sebocytes. And that's from the surface. These things often look like a papilloma or a wart. So it could be from the skin surface, or it could be that there's ducts within it that have got keratin linings. Okay, 3813, where are you? Here it is. This is a really common one that I would love you all to be comfortable to do in practice. But it's also quite challenging just because there's so much variation. So my first impression of this, just at low power, this is 5x again, is I've got big clear spaces. I've got some really dark stuff that looks pigmented and genuinely black. I've got some blood, and I've got some clumpy stuff. So there's a pattern, particularly down in this corner here, where things are sort of sticking together. Okay? That's my impression. So I'm going to look over, and these ones, I know instantly what they are, but I then have to make a series of proof that it's not X, Y, and Z as well. So I will not get close to these until I've looked all over the whole slide, and I'm looking for particular things. And we'll see if you can figure out what those are. Getting to it here. So if anyone wants to have a go at singing out loud to your colleagues so they can rib you afterwards, or writing in the chat what you think these things might be, give it a go. And I'm going to go closer here. I'm going to start out here. And nothing is ever quite in focus when you're dealing with these ones. And there's a spectrum. So I've got clear spaces. I've got clear spaces with some brown dusting in them. And you'll have to take my word for it that that's a negative space, but it's also a thing, not just air or a bit of the slide that didn't get covered by the plasma and the red cells in the background here, the tissue fluid and pink paleness. It's genuinely been held back by a non-staining thing. Then I've got some blue staining things and some slightly darker blue staining things and some purple staining things. And these are all a spectrum of the same process. Absolutely. Well done, Denzel. These are squames from a cysty thing. I don't get to write it that way in my reports, but that's exactly what I'm thinking. Squames from a cysty thing is exactly what they are. We've also got a cholesterol crystal here and possibly over here. I'm not sure. So we've got a couple of things. We've got some sort of maybe once were nuclei. Maybe there's some inflammatory cells here. Then I'm going to go, so I've got a cyst. Yeah, there are squames, assuming, and the way that they're shaped makes me really comfortable they came from within. They're not like the squames off the surface. This is a squame off the surface, and it's folded and rolled because it's been shed like that. But these ones are round and sort of blobby and not quite the same. There's more crystals. This sort of rectangular. Most cells aren't really rectangular to that degree. I'm going along the edge of the stained and unstained area here because it happened to be the bit that was interesting. And now I come to it. What I have here is a really difficult to focus and not very well preserved bit where I've got cholesterol crystals, which are apparently the shape of the state of Utah. If you've ever been to Utah, there's a wedge out of them. Then I've got this pigment, and I've got these really smushy, not well preserved, but there's dark blue round things visible. These are the nuclei. So I have got a little bit of tissue that has a lot of nuclei. So that's basaloid epithelium. So the structure of this cystic thing has more than just a couple of layers of squamous epithelium. It's got a bit more basaloid, which immediately pushes it to me into not just an epidermal cyst or a follicular cyst. It's probably a cystic epithelial neoplasm, and that could be a whole range of things. So most of them are just benign and not to worry about when they differentiate this well. Some of them are malignant. So that puts the comment from it's just a cyst to keep an eye on it. Take it off if it bothers the dog, take it off if it bothers the owner, and take it off if it does anything bad or grows. Some of them will metastasize, but that's really uncommon. But they do have the potential to be locally invasive and become quite problematic. Keratin is also really antigenically stimulating. So if they rupture or if your FNA leads to it being able to get inflammatory cells into it, off they flare and become really quite unpleasant. So there you go, a cyst with some epithelial components. Not perhaps convinced you all on that because it's not a great slide. And then the pigment is actually just because skin's pigmented. So it's okay for a cyst to be pigmented. It doesn't mean it's a melanoma. Right, where is 3560? Okay. Here's a segue. Just dumping the slide on for speed rather than going up and down. I've got clumps of cells. I've also got a scattering of cells amongst the blood, some of which are probably just from the blood. So I'm going to find some representative clusters of these cells, and I'm going to start zooming in to look at those in particular. And the art of this, the years of experience, brings me to knowing which clumps to look at from low power. And that's what causes the frustration for most of you in practice, is that you can spend ages driving around trying to find something good to look at and not knowing if something is just degenerate or not. So my impression at this power is that I've got really densely packed cells, lots of purple, not much pale in between them. So a relatively high NC ratio, mostly because they haven't got a lot of cytoplasm. NC ratio, because it's a ratio, it's one of those things that you shouldn't overinterpret. You can have a really big nucleus and a high NC ratio, or you can just have a lot of cytoplasm and a big nucleus, or a small nucleus and not much cytoplasm. All of those would give you different ratios, but not necessarily the same interpretation. So some bits of this are in focus. Try and look at the bits on the slide that are in focus, because it makes it hard if your eyes go squiffy with trying to focus on the bits that aren't when they're three-dimensional like this. The closer we go, the better it gets. Okay, that's about as good as I'm going to get it. My first jump to is these pigment clumps. I spot those and go, ooh, now I'm thinking pigmented processes. And I'm thinking very cellular pigmented process with small cells which have reasonably big nucleoli. And I'm seeing a bit of variation. I'm not really picking a shape for these populations, but I see they clump together. When they clump together, I'm thinking of things that are meant to hold together and things that are meant to cover, so epithelial and spindle. And I'm not finding it very easy to pick which of those it is. So I would drive around this slide for quite a while looking for more spindly areas. And with a fair bit of imaginoscope, you can sort of think, well, maybe this is spindly-ish. Maybe this one, a little bit spindly, but the others not so easy to pick. And looking for any evidence of differentiation towards specific epithelial components. This one, they're much more cohesive. I've almost got this scalloped edge to it, which is typical of more epithelial populations. And I'm looking for areas where they've teased out at the edge and I can see individual cells and I'm not really finding them. So the take-home message from this one is twofold. One is that there are two populations that tend to have a lot of pigment of this kind of black or green kind in skin tumors. And those would be the melanocytic tumors, melanoma and malignant melanoma, or melanocytoma, to call it the benign version, and pigmented epithelial tumors. And this is one where there's a fair fence for me here. I need to be a bit careful in how I phrase this to you. And I'm going to tend to lean towards the melanocytic tumor because that's the one I want you to respond most strongly to clinically. And I'd like you to take this off the dog and give the dog the best chance. And to be relieved if it turns out to be the non-aggressive type of pigmented basal cell tumor, for example. I'd rather you did that than leave it and think, oh, it's just a benign pigmented thing of epithelial basal cell kind of process, and then discover you've missed the chance to resolve a melanoma. The other things that can have pigment can be quite confusing. Things like breakdown products of red cells. So hemosiderin can, in an area of prior hemorrhage can look like this, and we can get confused cytologically and histologically. Sometimes we do special stains, or sometimes we just err on the side of caution. So that's a pigmented one. I would have called this one a melanoma, but it's subtle and hard to convince. So it's one where you really would want to send that to us to give you the opinion. Okay, what else shall we tackle? Any particular things you'd like to see? Because I can just keep going. Okay. I'm going to try this one next. This is a good one. This is another submandibular mass. Again, dog, because the vast majority of the cases I've put aside are dog. This is lovely. Body cavity effusions. I have a couple of those. I'll give you some of those next, because those are really good for first-line practice when you need an answer. And I'll give you some tips on how we manage fluids, what we do with our chemistry, and all those things. Now, this is dust and debris, so don't worry about that. It's not a fungal process. It's just my slide is dirty. I'm really careful with wiping my cytology slides because we don't cover slip them so that we can restain and handle them and process them really quickly for you. And I'm always the limiting factor in that, and I apologize if I get too busy and it falls over to the next day. I do try and prioritize and triage for you at least, so that the urgent sounding things get done first, and that's why it's so good to give me history. If you tell me the dog's sick or the cat's dying, it gets bumped to the top of the pile. So this is a mass fluctuant soft under the jaw sort of here, if you can see that. And this is a classic profile. When you look at the pattern of these cells, with the occasional clump, but most of the time we've kind of got buckshot, but we've got variation in size. We've got an effect of cells are variable. Oh, just gone out of focus. Slide wasn't quite mounted on the stage well enough. Go back and start again. If you can't focus at your 40, you probably got your slide the wrong way up. Spent far too long wasting my time trying to focus when actually the slide was just on the wrong side. You'll focus just fine at 10 and 5, and then suddenly you'll be, I can't focus. Okay. So when I get really close to these cells, there's a number of things I can see. There's some variation. So I've got, this is an apoptotic cell. There are 3 blobs of nucleus stuff. Thank you. 3 blobs of nucleus stuff that are separate, and it's just aged. So when the cell looks like that, it's just aged and it's deliberately dying by programmed cell death or apoptosis. These ones are still intact and large and foamy, bigger than the red cells, and they've got bluish blobs in, and then there's blobs in the background. And then we've got these big ones here, which are variations on a theme. And you'll have to take my word for it that these are actually the same cell type. These are more macrophages, these ones and these ones, just doing different degrees of big eating. So a process where we've got a background of bluish, slightly sticky looking stuff and some crystals, pretty, a little bit of a breakdown crystal of cell breakdown. Macrophages doing a lot of eating of stuff that's bluish, grayish, mucky, and sometimes darker pigment, maybe some hemosiderin. That does not get the white balance. Let's try that. No, it's not going to give me the nice white balance that I want. But little bits of blackish stuff on here that I can see on the scope, and a few neutrophils. This is a sialocele, but one that's had some hemorrhage into it and some tissue breakdown. Sometimes they just look more foamy. Sometimes they have background stuff. Sometimes they have cell debris. But the process is the same. It's not always easy to make as a first call in practice, but it's a useful differentiator. There are not high numbers of neutrophils, so it's not a pharyngeal stick injury. There's a viscous sort of thick proteinaceous background, which is useful to spot. So body fluids. Cool. Okay, so where are we going to start with on those? Over here. 7, 8, 9, 2. Okay, now this is a nice one because I want to show you on the big screen. I might just stop sharing for a moment so you can see me bigger. Okay. Can you all see me? Probably. So I'm going to teach you a little bit about how we prepare body fluids. So the first one is a simple one, and you might need a piece of paper behind this. So it's just a direct preparation, made exactly the same way as a blood smear. It's a dot of the fluid at one end and then pulled away to the end. This is quite a viscous one, so it's it's done that quite comfortably and all been on the slide, so from one end to the other. What I also like to teach people to do is, and this is really, really useful when you're in practice. So instead of making a blood smear type prep, it's almost the same. You put the dot at the head next to the frosted edge, but you use your spreader slide, you pull back. I can do this backwards. I'm going to do it cat-handed, but there we go. So you pull back, and then you use your spreader and you pull it along. But instead of going all the way to the end and taking off like an airplane, I'm going to do it on the back because I've got oil on it. You pull back into the smear, and then you go along, and then you leave it attached. It's still standing there, and it's attached, and I lift that vertically. So it's for those of you who are into planes, it's a Harrier jet suddenly. It's vertical takeoff. And what that's done is it's given you the stretched out area where the cells have been distributed. And at the end, where the line is, where you lifted, that's given you the track in the dirt of all the concentrated cells that have been placed in that line. They've stretched along, you've got them concentrated. That's what you want to do for your less cellular fluids. And that's almost as good as what we do in the lab, which is this. And more pieces of paper. Okay, so this is a cytocentrifuge preparation. The black line is where the scientist has kindly marked it for me so I can see the purple dot in the middle. Not a problem in this case, my eyes are good enough for that, but if it's a low cellularity fluid, it can be quite hard for me to find that dot. And that dot is created by using one of these. And this is a cyto preparation connector. I put the slide in the middle. I put the fluid by pipette in this little hole here. And then I centrifuge it so that the fluid is pushed through a filter layer and in a little circle in the middle. The cells come through, the fluid gets sucked off into the filter paper and then absorbed. And I end up with a little concentrated spot of all the cells. So I'll do that for my CSFs, my BALs, my body fluids, sometimes the really watery joint fluids. And if there's a cyst fluid from a mass or an organ, we'll do that as well. And that will end up with this preparation where I can look at the cells and they're really nicely flattened out. So let me show you how they look. Try not to get oil on the back of my microscope. So this, better start sharing. And that's great. Oh, good. Okay, so this is my direct prep. And with the direct prep, when I've got the cytospin or the line prep, I'm only just floating over this at low power. I'm just looking for cellularity. I'm looking for blobs. I'm looking for distribution. And if anything piques my interest, I'll just go down and have a look. I'm not going to feel like I have to look at every square millimeter of this slide. It's a representative process. So I've seen some blobs. I've got an assessment of the cellularity, and I'm looking for anything unusual. So things that I've picked up at this power, this is 5x. What I've noticed is that the background, and if I go to the edge of the slide, you'll have a contrast of color. Sorry, this is a little nauseating. I'm going the wrong way, that's why. So don't look aside. So do you see this is the bit with no material, and that's the background color. And this is the bit with the material, and it's pink. So that tells me that there's protein in that fluid. it tells me just subjectively that this is not a transudate. This is going to be a proteinaceous fluid. So I've already made a connection there. I've also got these little, now this is a hair, a fiber of some sort. It's blue, so it's probably a dress I was wearing or something. Then there is a little bit of blobs and these are protein crescents, and they occur when the fluid is viscous enough that the protein doesn't just slide across it. So they again imply a proteinaceous fluid. Now, this one isn't too globby, but I would be very much cautious in making a clinical, very favoring the machine safety, but you can put these through the machine with caution and against all advice to get an account of cellularity, protein, and my reports will give you, for example, cholesterol, triglyceride, bilirubin, urea, creatinine, and if I ask for amylase and lipase, all of which are going to give you information about the process in a body fluid. Pancreatitis cases will seep pancreatic enzymes everywhere, and the concentration of amylase and lipase in the peritoneal fluid can be massive and monstrous and painful. I'm not surprised these dogs are just curling in on themselves with pain. If there's a uroperitoneum, for a little while before it equilibrates, you will have a higher concentration of creatinine in particular in that body fluid than you will have in the serum. If it's chylous, then triglyceride and cholesterol levels are critical to interpretation, and obviously the protein makes a difference to how we put it all together. Now, in terms of the cellularity, even just sticking with the direct prep, this is really cellular, and what I want you to fix in your mind is your typical well-made blood smear, and the monolayer of your blood smear. If you put one aside, give yourself a good example of dog, cat, horse, cow, pig, whatever. You probably don't see many pig blood smears. Nobody ever seems to get those. But a nicely well-made blood smear, in the monolayer, what you'll get is the typical distribution of white cells that's within the normal range for a dog. Now, from memory, something like 5 to 13. When you think of that distribution, and you remember that an exudate is anything above about 3.5, if it's got as many cells as the blood smear monolayer, it's an exudate. So classification-wise, you've seen the background, you've seen that there are more cells than your typical blood smear. This is an exudate. So we've already got a long way down this process. And we haven't even got close. So I'm going to go close and show you what these cells look like on this direct prep. And then I'm going to show you how much better they look on the cytospin that I get. So what I'm seeing is a variation in cell size, big ones, small ones. I'm seeing some that look a little bit segmented and some that don't. And some free nuclei, but even a free nucleus, you can tell it used to be a neutrophil. It's all bloaty and lysed. So some neutrophils, 1, 2, 3, 4, 5, maybe this one, and some foamy cells of varying sizes. These would be the macrophages. These are free nuclei, so I'm ignoring them. Right, and this is a basket cell. It's just like chromatin, just forming a basket of remnant debris. And then I'm going to go over to my cytospin, and this is where I would usually bother to do the most time in interpretation, because the cells are beautifully spread out. They're all nicely flattened. They're all put together for me to make it easier. I don't have to move so much. Goodness, twiddling my thumbs is such hard work. So I will pop my oil on there, get down and scout around at 40x. And because I've already decided it's an exudate, and can I remember anything about this process? It's a 6-year-old Italian greyhound with a plural exudate. Okay, so not what we were expecting. Unusual history. 6 years old, doesn't put us into any nice categories. Italian greyhound, so more scared of itself than likely to be running into anything or eating foreign bodies. And not a cat, so it's not FIP. So what I did was I spent ages and ages looking in the neutrophils trying to find bacteria. And I made a note to myself that I didn't find any because I knew I could spend ages and ages showing that to you and trying to find them. What I've got here is a macrophage that's eating a red cell. So there's been a tiny amount of hemorrhage, not much because there's only a few red cells in the background. I've got a macrophage eating a degenerate bit of something, some sort of cell, and maybe another bit of cell in a macrophage here. The macrophages are bloaty and busy. The neutrophils are variably sort of aged and lysed and bloated and degenerate, and also completely normal. So I don't have an answer. I have a process and a variety of pathogenesis possible. So what I've said in this report would be something along the lines of pyogranulomatous exudate, no cause identified, because I didn't see bacteria. I would still encourage you to culture. I would encourage you to be imaging, looking for a mass, because if this dog has a pneumonia in a lobe or extensively, you can get a pleural effusion because of seepage out of ruptured bully and where the exudate can get out of the lungs and into the pleural cavity. You'd be thinking about foreign bodies. You'd be thinking about migrating grass thorns. Usually they're septic, but not every time. You might think about, gunshot wounds, depending on where you live. When I studied in Glasgow, that was quite a common occurrence, maybe mostly air pellets, to be fair. But things like that. Is there a tumor that's become necrotic? Is there something that's put inflammatory focus into the pleural cavity? Cool. So we've got 5 minutes left, which is about right to start wrapping up. If anyone wants to put some questions in, then I'm happy to answer questions. Otherwise, I will just show you. Can I have 2 minutes on the spindle cell discussion? This is one that is a huge source of frustration for you, and we fully understand your frustration and feel your pain. I can even find this slide. Oh, there we go. I've got them mixed up again. 2622. The problem, canine vaginal cytology. Oh gosh, this is where I get really crude. I'll give you some tips on canine vaginal cytology and how I remember the stages. Might just do the spindle cell one first while I psych myself up to that one. Okay, so spindle cells. This is a really lovely example of the classic appearance of spindle cells. We've got great long streaming edges. We can't really always see the nice sharp margins, and let's just give it a little bit more of a tweak. And spindle cells are the body's response to healing, as well as holding things together. So in your scar tissue, I've got one on my pile on my desk today that I'm really not looking forward to, and its history says something along the lines of mass removed 3 months ago, sickening at the scar site. And I'm dreading it because I know that there's going to be spindle cells, and it's going to be that age-old argument: are they reactive fibroblasts, which can be weird as all get out, or are they neoplastic? And hopefully it was a mast cell tumor or something else entirely before, and I'll find the tumor. But the likelihood is that in that scar, I'm just going to get all the inflammatory response, including the leukocytes and the spindle cells and the collagen, and I'm not going to be able to give you anything. It's certainly not useful for exclusion. It's only useful if I find the tumor. And if you tell me what the tumor was, that's going to help me. Particularly if you didn't send the histo to us to start with, I could do with that report so I know what they saw. So the spindle cells, as a reactive process, are normal, and they can be wild and freaky, all the features of malignancy. And the spindle cells in a tumor can be boring as all get out, or they can be wild and freaky. And it's really hard to tell the difference. This is one of those very few examples where I would stretch my neck out and metaphorically put it on the block, ready for you to prove me wrong with histo, because I did actually have a few of the particular spindle cell morphology that's a classic for one particular subtype of spindle cell tumor. Not a great example because it's actually a lysed cell. But can you see how the nuclei form a little ring around the outside? This was a crown cell. I'll see if I can find another. And this one here, with the two nuclei at opposite ends of the cell, a polar nuclear arrangement in a binucleate cell, are features of a perivascular wall tumor. And that's the one that you'll get from me with the report that says, I strongly favor a perivascular wall tumor, which is useful in that it makes it more consistent with tumor, but not useful in that those tend to be the more lower grade tumors. So not definitive, not necessarily going to give you everything you wanted out of a cytology report. But what it does tell you is that you can plan your margins. You need to not shell these things out. You need to make sure that you're aware that they can track down fascial planes and that they will infiltrate, like little tendrils, and that you need to send us the whole thing. If you have to take a deeper layer separate, put a suture on one side of it, tell us which side, so that we know and can ink appropriately to how that fitted into the dog for your margin assessment. And if you take an incisional biopsy from these, be aware you're only doing it for grading, and these things can vary. If you've got a mass that's 5 centimeters, I can guarantee there'll be some bits of it that are necrotic and some bits of it that are not. And if you hit a necrotic bit and 50% of that tissue is necrotic, I'm going to grade that with a score of 1 for that, and then that's going to pump it up into the higher grade. Whereas if I see the whole tissue or representative sections of the whole tissue, it might drop down a grade or 2. So grading can vary depending on where you look within your spindle cell tumors. But it does give you a good start to know how to plan things. We've gone over time, so thank you all for attending. I can stay behind and answer the vaginal cytology question. Cytology textbooks I will also do. Here are my 2 favorites. Oh, I'm going to stop sharing so you can actually see me. Okay, so this is the newer version, the green one, which is Rose Raskin's book, and this is Cowell and Tyler, both amazing pathologists, both very pictorial, both very detailed. So the BSAVA manual is a good start if you don't do that much cytology, just for a few examples. There is some older textbooks, and realistically, you might well be able to get away with old versions if you're trying to keep your budget down. This is a pretty good textbook. It's been around for a few years, but the basics are in there, and there's chapters on fluids and analysis and vaginal cytology and things like that, and a picture of a variety of squames, and everything with cytology is pattern matching and process consideration. So those are all good. Vaginal cytology, I think of it as preparation for trauma. So, and mopping up after trauma. That's my crude way of remembering how it goes. In anestrus and in juveniles, there's no expectation of any trauma. So there doesn't need to be more than 1 layer of epithelium, so it's basal. As the likelihood of physical trauma increases, the thickness of the epithelium increases. So you get first intermediate and then squamous, because it's got to have a nice thick layer in there to protect from the mucosa from being disrupted. So as you get closer to estrus, the number of squames will increase. And in preparation, you will also get some neutrophils to mop up afterwards. There you go. Simple as that. Can I hold up those texts again? Yes, absolutely. We can also get Kim to put the video with the links. So Canine and Feline Cytology, 3rd edition by Rose Raskin and Danny Mayer. Nice green one, pictures. And the other one is Cowell and Tyler's Diagnostic Cytology and Hematology. The hematology in this is great for a summary. And that's the 4th edition, and there might even be another one now. Because Rick Cowell's retired, but still doing all the things that pathologists do. We never quite die and go off on holiday, we keep working. Okay, do I recommend rinsing between the stain 1, 2, and 3? No, don't need to. Rinse at the end, just under the tap. But yeah, into the fixative and then tip it off, and that's it. Then into the 2nd, and then into the 3rd. 6 dips is never quite enough. Give it a couple more. And you can go back and do it again. So if it's too blue and not pink enough, you can go back and do stain 2. If it's not blue enough, go back and do stain 3 again. Now, if you are trying to teach yourself cytology or learn, take your slides and keep one and send me some more that are also good. And then look on VetConnect Plus, because I'll have taken you some photos. The quality will vary. Sometimes I'm looking on my screen and my eyesight isn't that fantastic, so I'm focusing, my microscope will focus perfectly for my eyesight if I set it up properly, but I might look at the screen as a bit blurry, but they're there, and they're there for your resource. And often I take quite a few because I also use them internally for training or for second opinions. And we do our consensus rounds, and sometimes we'll just go into VetConnect Plus and look at those photos and say, these are the highlights of what I saw. What do you all think? And get that discussion going on those cytology pictures. So thank you all for coming. Sorry I went over time again, too enthusiastic. And thanks for giving up your lunch break. And very much appreciate all the feedback and all the communication about the cytology cases. I really appreciate the history. Nothing makes me do a better pathology report than a good, concise, detailed history that gives me what I need. Thank you all.